Dr. Elise Kramer, and today I'm going to be talking to you about how contact lenses can aid in ocular surface health. And today dry eye and ocular surface disease is a very hot topic. And of course, contact lenses with new technologies, new developments available, makes these things intertwine together. And it's so interesting to see how we can use contact lenses to aid in ocular surface health. So about me, I graduated from optometry at the University of Montreal in 2012. I did my residency in Miami at the VA Medical Center, and I spent a lot of time training as well at the Bascom Palmer Eye Institute. I then became a contact lens specialist and dry eye specialist and became a fellow of the Scleral Lens Education Society. I'm now the treasurer of the Scleral Lens Education Society. In a couple months, I'll be the secretary. I'm also a member of the American Optometric Association, fellow of the British Contact Lens Association, member of the International Association of Contact Lens Educators, fellow of the American Academy of Optometry. I practice currently in Miami and Weston, Florida. And if you want to reach me, you have my email on Instagram and Twitter there available, and I'm also on LinkedIn. So these are my financial disclosures. So let's start with what is the definition of dry eye, and the TFOS DEWS-2 study came out, and this really revolutionized the definition for us. So now we know that dry eye is a multifactorial disease of the ocular surface characterized by a loss of homeostasis of tear film and accompanied by ocular symptoms in which tear film instability and hyperosmolarity, ocular surface inflammation and damage, and neurosensory abnormalities play etiological roles. For me, in this definition, there's two, obviously every word is extremely important, but tear film instability, hyperosmolarity, and inflammation are all key components of understanding dry eye. And I think also homeostasis, loss of homeostasis, and trying to restore that homeostasis is really key to understanding why we use the treatments that we use. So the TFOS DEWS-2 study came out with this flowchart that I think is really interesting and also a great just breakdown for clinical practice. So if you have a presenting patient starting at the top, and they are asymptomatic, okay, and they have no signs, then they're normal, right? There's no treatment required. If they're asymptomatic and they have signs of ocular surface disease, then you're thinking maybe it's neurotrophic, and it's important to test for corneal sensitivity in those cases and then treat accordingly. If they're asymptomatic and they have signs, but again, they don't have symptoms yet, then that actually could just be a predisposition to dry eye. So again, important to test sensitivity in those patients and determine if they're neurotrophic, or if maybe they have sensitivity, but perhaps they're not feeling the dry eye yet. But the fact that they have signs, if they're doing any type of surgery, or if you're sending them out for any type of procedure, it's important to practice preventative management at that point because the symptoms will probably come along shortly. Let's talk about the symptomatic patients now. So you have a presenting patient that's symptomatic and they have signs. At that point, it's important to ask questions, determine what is the ocular surface disease because there's many, so you have your differentials, and then treat accordingly based on what we find. If they are symptomatic and they have signs, if they're symptomatic and they have no signs, at that point you're thinking maybe it's neuropathic and they should be referred for pain management and not for dry eye treatment. If they're symptomatic and they have no signs, this just could be a preclinical state in which they're feeling it and the signs may develop later on. So again, preventative therapy in that situation. So when we talk about dry eye disease, obviously there are other ocular surface diseases that can mimic dry eye, And so it's important to use appropriate diagnostic testing in order to differentiate the different types of ocular surface diseases. And dry eye itself can actually be broken down into aqueous deficient dry eye, evaporative dry eye, which is predominant, and actually there's a lot of cases that are going to be mixed. So the management for ocular surface disease, for dry eye disease, is going to be, again, restoring that homeostasis. Because remember, the definition of dry eye disease is a loss of homeostasis. So when we do apply any sort of treatment, it's going to be to restore it. So let's talk about the difference between aqueous deficient dry eye and evaporative dry eye. So both of these are different types of dry eye, but you can see that they're both kind of related in the sense that they both play roles causing inflammation, tear film hyperosmolarity, tear film instability, which eventually leads to more inflammation and the release of inflammatory mediators. So this is a vicious circle that needs to be interrupted, but the only way that it can be interrupted is if we figure out, is this evaporative, is it aqueous deficient, or is it mixed? So when we talk about aqueous deficient dry eye, we talk about the fact that there's just not enough tears being produced, and there's several different reasons that could happen. One of them is Sjogren syndrome, but there's also refractive surgery and just a reflex block. There's systemic drugs that will decrease tear film production, lacrimal obstruction, autoimmune diseases, and many other different causes. Now, when we talk about evaporative dry eye, we talk about dry eye disease in which there is enough tears being produced, but they're just evaporating excessively. And again, both of these different types of dry eye are going to lead to severe inflammation. And if it's not treated, if this cycle, this vicious cycle is not interrupted, then it will just perpetuate. So when we talk about evaporative dry eye, there's meibomian gland dysfunction, which is a huge, just very common condition, anterior blepharitis as well, just deficient unstable lipid layer, and vitamin A deficiency, but there's many other causes. And of course, as I mentioned, you can have a patient that has both types of dry eye. So it's important to isolate the etiology, whether it's aqueous deficient, whether it's evaporative, or whether it's a combination of both, in order to find the right treatment. And when we talk about the role of biofilm, this is the anterior blepharitis. And this is just bacteria living on the surface, on the eyelids, on the eyelashes, that can exacerbate evaporation, that can create contact lens intolerance, that can just cause just dryness symptoms, redness, grittiness, and overall inflammation. So the biofilm should not be ignored and should be addressed appropriately, because it will evaporate, exacerbate any type of dry eye that you already have. And this is just an example of, Demodex, of anterior blepharitis patient that clearly has a thick biofilm, which again needs to be addressed in the treatment for dryness. So when we talk about dry eye, the first step is always going to be education. So we need to go and talk to our patients and help them understand how they can treat this at home. They need to understand what's going on, why they have dry eye, and what the preliminary treatments are. So if they have evaporative dry eye, we're going to be educating them on hot compresses, which is going to help evacuate the meibum from the meibomian glands and restoring the function of the meibomian glands, preventing loss of meibomian glands, and helping them function appropriately. Artificial tears will help lubricate the ocular surface, replacing that tear film, or helping with the tear film instability, and eyelid hygiene, which should be cleaning the eyelashes, just that biofilm twice a day, and then omega-3. So this is basic. These are things that patients can do at home that they can incorporate into their daily routine in order to see a difference in symptoms. And then when we go back to the TFOS-DUES-2 study, we look at all the things that they recommend, that they've studied in order to address dry eye. Now we can actually see that rigid scleral lenses is going to be there, is considered a treatment for moderate to severe dry eye. And so we can see that contact lenses can actually play a role in helping with ocular surface disease. So let's talk about scleral lenses and how we can use those for ocular surface disease. What are medical indications for scleral lenses? So we can see there's actually 62 different indications for scleral lenses. But if we talk about medical indications, we're talking about dry eye, whether it's caused by Sjogren's syndrome, neurotrophic keratopathy, rosacea, chemical burns, or undifferentiated dry eye. Cicatrizing conjunctivitis, whether it's Stevens-Johnson's, OCP, there's corneal dystrophies, degenerations like Salzmann's nodules, Terrien's marginal degeneration, RCEs, exposure keratopathy for just post-eyelid surgery, nerve palsies, exophthalmos, graft versus host disease, atopic keratoconjunctivitis, hypoanesthesia, limbal stem cell deficiency, vernal keratopathy, persistent epithelial defects. So all of these indications have been established as ocular surface diseases that can be addressed with scleral lenses. So in this case, what is a scleral lens doing? It's going to be protecting the ocular surface and restoring it. So in this case, the scleral lens provides a hydrating kind of dome that will sit on the eye and protect it from the outside environment, protect it from whatever is aggravating it, protect it from all the things in the environment that could be just causing this dry eye, and creating like a force field around the cornea, around the conjunctiva, and protecting it from the eyelids, protecting it from any bacteria, debris, deposits, and anything that can be causing the dry eye, such as exposure keratopathy, for example. So if we look at this case, this is a severe ocular surface disease. We can see the thick staining, 4+ severe SPK on the cornea. And this, is probably caused by just aqueous deficient dry eye. So what would a patient feel in these cases? Discomfort, just increased blinking, increase in lacrimal tearing, secretion, just overall just discomfort, pain, grittiness, redness. This is aqueous deficient dry eye. I personally love to use a questionnaire in office. I love the OSDI. It allows patients to answer questions about their quality of life and address how dry eye is affecting their everyday, when it affects their dry eye, and I think when it affects them. For example, is it in the morning? Is it in the afternoon? Is it in the evening? Is it all the time? And then using this questionnaire, you can actually grade their dry eye based on their subjective answers. And then if you initiate a treatment, you can actually redo this questionnaire and see if you see any improvement in quality of life. And that allows you to monitor how your treatment is working, maybe not clinically, but in terms of, and not for signs, but in terms of symptoms of the patient. And so that can be significant. So lissamine green is something that I also use for diagnostic purposes very often in order to stain the conjunctiva. It's excellent because it will show dead and devitalized cells on the conjunctiva. You can also see the lid wiper epitheliopathy here at the bottom, which we know indicates just a more severe kind of dry eye, which indicates a lot of friction between the palpebral and bulbar conjunctivae. And again, that lid wiper epitheliopathy just highlighted here, which is best seen with lissamine green. And then fluorescein is an excellent dye as well, which is best to show dead and devitalized cells on the cornea. So just an excellent diagnostic tool as well when you're talking about diagnosing dry eye. There's other diagnostic tools that are that we learn about in school, that we learn about in residency, that are applicable as well. Inflammadry is something that will show how much osmolarity. If there's hyperosmolarity, we know we have inflammation. The show test is going to be a test for to determine if a patient has Sjogren's syndrome. Obviously, the best type of test to determine if a patient has Sjogren's syndrome is a salivary gland biopsy, but this is definitely clinically useful as well. And then the phenol red thread test and the Schirmer test will help determine what is the basal tears or reflex tears that a patient has. In the phenol red thread test, if it's less than 15, we know it's abnormal. In the Schirmer test, if it's less than 10, we know it's abnormal. So we know that scleral lenses can provide improved vision, improved comfort, and are absolutely indicated for ocular surface disease. They're actually superior for ocular surface disease than rigid gas permeable lenses, which can help correct vision significantly, but can also cause complications such as in these photos, you can see the 3 and 9 o'clock staining, which when a scleral lens is appropriately fit, will not see at all. This corneal vault in scleral lenses can protect the cornea from mechanical insult and external irritants, as I mentioned, and therefore they can be considered not only as a problem solver, but also as a viable alternative to smaller rigid gas permeable lenses. So this study was done by Levitt in Europe, showing that corneal rigid gas permeable lenses are actually less comfortable subjectively than scleral lenses, so larger diameter lenses. So this was a head-to-head study comparing the comfort with corneal rigid gas permeable lenses versus large diameter scleral lenses, and again showing that subjective comfort scores were significantly superior for scleral lenses, which means that scleral lenses can actually be more comfortable than rigid gas permeable lenses, which is why they're key for patients who have very symptomatic ocular surface disease. So a scleral lens, as I mentioned, creates a tear film reservoir which will cover the surface that the lens covers. So if you're covering the cornea and part of the conjunctiva, then that part will be in this oasis that you're creating in the scleral lens. And you can see on the OCT in the image above, the cornea, the tear film reservoir, and the scleral lens on top. So it really is like an oasis. And as long as the patient is wearing that scleral lens, that's when you're going to have the hydration. So if they're wearing the scleral lens for 16 hours, you have 16 hours of hydration. You have 16 hours of restoration, of protection of the ocular surface. And you can actually fill the scleral lens, not just with preservative-free saline solution, but with a cocktail of various products that are preservative-free, such as antibiotics, such as moxifloxacin is preservative-free. You can add autologous serum tears. You can add amniotic membrane drops. You can add preservative-free saline, artificial tears again. Whatever it is that you want to put in there to promote and optimize the ocular surface, you can do. And as long as the patient is wearing the scleral lens, they're going to have those products on the surface of their eye. So of course, it's very important to be selective with the products that we're using on the ocular surface, but it's also important to keep in mind that the patient will have this hydration on the surface of their eye the entire time they're wearing the scleral lens. So if we look at that initial cornea I showed you a few slides ago, and after wearing a scleral lens, you can see how much that surface improves. And I think it's just important to go back and just look at that significant improvement that you see just by wearing a scleral lens. Impressive. So let's talk about severe dry eye and ocular surface disease. So we know that scleral lenses have the ability to improve anterior ocular surface health and reduce symptoms in patients for reasons that I already explained. But we have to take into account other things when we talk about scleral lenses. So we do have this pre-lens tear film. So we have the pre-lens tear film. We have the scleral lens, which is the layer right underneath. Then we have the tear film reservoir, and then we have the cornea. So a contact lens must have an even and continuous pre-lens tear film. So we talked about the post-lens tear film a lot. We talked about the tear film reservoir, which is the post-lens tear film, but we haven't yet talked about the pre-lens tear film. So the pre-lens tear film has to be optimized to have comfortable lens wear and to have best corrected vision, because this is going to be the first refractive index that light is going to touch before it gets to the lens. So despite advances in materials and surface coatings of scleral lenses, it's especially challenging to achieve a good pre-lens tear film for patients who have dry eye, but who are otherwise successful with scleral lens wear, because the scleral lens is promoting a healing of the ocular surface. But what about that tear film instability that you have on top of the lens? That needs to be addressed as well. So what happens if we don't address this is we can have poor lens surface wettability. You can see here just mucoid, lipid, or protein coatings on the lens surface. And that could be from giant papillary conjunctivitis. It can be from vernal conjunctivitis. It can just be from just dry eye tear film instability. But the symptoms is going to be dryness. It's going to be intermittent blurred vision. Obviously, if this is the refractive index that a patient is looking through, is at the first surface, look how irregular it is. It doesn't matter what the scleral lens is doing, the patient will not see well through that. In order to address this, you would have to frequently remove the lens, and you would have to clean it and put it back on, which can actually exacerbate the production of mucoid, lipid, and protein, which can then just worsen things. So the actual act of like removing and putting the lens back on, that's kind of a fishing syndrome, which can just perpetuate the problem. So what do we do about poor lens surface wettability? Obviously, the first thing we want to address is managing lid and ocular surface disease. So if a patient also has evaporative disease, we talked about education, we talked about hot compresses, omega-3, preservative-free artificial tears, sometimes with lipid, that helps as well. And of course, a lid hygiene at least twice a day. If they do have allergies, that needs to be addressed by ideally eliminating the allergen or treating allergic conjunctivitis with an appropriate pharmaceutical agent. Reviewing skin and care and makeup regimen is important. So it's always important to do makeup and use creams after the lenses are applied, because if they're applied before, when the lens is, if skin care and makeup is done before the lenses are applied to the ocular surface, then as the lens is going in, it can actually absorb or rub on a lot of those products and just be dirty and cause a hydrophobic surface. So it's important to review that. Also, they may want to eliminate a lot of just hydrophobic products that can prevent the normal wetting of the scleral lens. You might want to improve the cleaning regimen, so use an extra strength alcohol-based cleaner. Peroxide cleaners are also really good. And other things that you can do to troubleshoot without removing the lens is using a wet Q-tip, just wetting it with a solution or even saline, or just use a DMV plunger and wipe the deposits off. You can choose a lower wetting angle when choosing the material, and there's also, of course, plasma treated. All lenses should be plasma treated, and then HydroPeg is something that you can add. It's a surface coating that you can add to the lens in order to improve its wettability and interaction with the tear film. So let's see how that works. You have a plasma-treated scleral lens, but just poor wetting. The tear film is unstable, the lens is unsuitable. But when we add HydroPeg, it just becomes clear. It interacts so much better with the ocular surface. It promotes a stable tear film across the lens surface, and creates a hydrophilic lens surface. Other things that can happen in ocular surface disease is when you have just debris in the tear film reservoir. So this time underneath the lens. So this happens by fluid dynamics under the scleral lens, which basically attract deposits. There's like negative pressure that is attracting deposits from the tear film, from the eyelids, from the eyelashes into the tear film reservoir if the limbal clearance is excessive. And also, if there's no tear exchange at all, this can cause a lot of debris accumulation over time. So this will cause decreased visual acuity. People complain of fogging. This is midday fogging in essence, and the patients find themselves having to remove their lenses in the middle of the day, which is extremely inconvenient, especially if they're not home, and then just putting it back in, which, as I mentioned earlier, is kind of a fishing type of condition that can actually exacerbate the production of debris, which can actually make the condition worse. So repeated lens removal is not the answer. So how do we treat this? Basically, again, the first step is going to be treating any ocular surface disease, any eyelid deposits, whether it's Demodex, whether it's anterior blepharitis, using hot compresses, eyelid hygiene, omega-3, maybe doing in-office treatments like LipiFlow, like tear care, just to address these evaporative conditions. You can modify the peripheral curves or reduce the lens diameter. Flattening curves basically will minimize the impact on the conjunctiva, so will improve tear film exchange. And you can also modify the curves to reduce limbal clearance, because remember that excessive limbal clearance will cause that negative pressure and attract debris into the tear film, into the tear film reservoir. Another thing that works quite well actually is mixing viscous artificial tears inside the bowl of the lens. So earlier on when I talked about the oasis that we create under the scleral lens, I talked about other things that you can add in addition to preservative-free saline. In this case, in order to just keep the debris away from the optic zone, you can actually use a more viscous artificial tear inside the bowl of the lens, which will essentially maintain that clarity and prevent fogging, and it works really well. Another thing you can ask the patient to do is to just tilt their head and flush their tear film with saline without removing the lens. So that's another thing that you can do. Again, we want to avoid having the patient just having to put in and remove their lens. But sometimes they have to do that, and they might have to remove it, replenish with fresh saline. And again, as I mentioned, frequent application removal will promote more disruption of the ocular surface and more debris. So that's just really not ideal. So let's go over some cases about aqueous deficient dry eye. This is a 51-year-old female who came in for a scleral lens evaluation. So she has a history of Sjogren's syndrome, keratoconus. She tried doing LASIK in the right eye, so she has a flap, but they actually didn't do the treatment. And for dry eye management, she was previously treated with cyclosporin, lifitegrast, and punctal plugs. So she's wearing frequent replacement soft lenses, but complains of very poor vision. So she does have keratoconus, irregular astigmatism, ectasia, and that is difficult to neutralize sometimes with a soft lens. So she tried hybrid lenses, but they were really uncomfortable for her. And her current spectacles, she's seeing 20/40 in the right eye, 20/20 in the left. So it's not a super advanced keratoconus, but you can see that there's a lot of astigmatism. And her best corrected visual acuity with these spectacles is only 20/40 in the right eye. So definitely room for improvement there. So she was fit with a 16.5 millimeter freeform customized scleral lens manufactured in optimum material with HydroPeg coating. So we proactively added coating because we know she has dry eye, she has Sjogren's syndrome. So we want to improve her chance of successful wetting based on her dry eye. And she was able to get 20/20 vision in both eyes, which is expected and, obviously desirable in a patient with keratoconus. And we instructed her to clean with Clear Care, which is a peroxide solution. So her first follow-up visits, she reports that the right lens wasn't always wetting. She also has some symptomatic midday fogging of her left lens. And the left lens also fits slightly loose. So we reordered and dispensed a left lens with a steeper landing zone to help with the midday fogging and just the loose feeling of that lens. So that helped, but 9 months later, the midday fogging resolved, but neither lens was wetting well. And so, you can see that there's significant deposits on the left lens. The poor wetting of lenses can actually increase lens deposition. So if you talk about a lens that's just not wetting well, it actually can attract even more debris just because it's not wetting well. So the fact that there's lipid and protein is actually going to attract even more protein and lipids. So it's just something that perpetuates and just becomes worse if it's not addressed. So there's actually a booster solution for lenses, which allows for a longer symptom-free relief. So again, we preemptively put HydroPeg on these lenses, but 9 months later, it was already not working. And so that's where the booster solution works really, really well in order to improve. Because this was only 9 months later, and we definitely don't want to be replacing scleral lenses every 9 months. A lot of insurances won't pay for that, and patients certainly won't want to pay for that. So it's important to address this, and we have these booster solutions now, so that's great. All right, let's talk about another case. So this is a patient who was referred, a 4-year-old girl. She was referred for a scleral lens evaluation. She was born with MODA, which is Manitoba Ocular Trichoanal Bifid Nose. And basically she has these acquired corneal opacities of mild density because she has exposure keratopathy. You can see just like an overall coloboma of her eyelids. And there was multiple procedures that were done. She had just multiple reconstructive surgeries, including tarsorrhaphies. She presented with bilateral corneal opacification and scarring. She has severe amblyopia. Remember, she's 4 years old, and symblepharon. So the only thing that she was using was just preservative-free artificial tears at this point. She had tarsorrhaphies, as I mentioned, but she had significant findings were bilateral upper eyelids with scalp margins, like you can see in the photos. You can see the tarsorrhaphy, bilateral symblepharon, and corneal opacification, which was a little bit worse on the left than the right. This is her spectacle prescription, so you can see a lot of irregular astigmatism there, at 2150, 2400, so just a pronounced amblyopia. We did a corneoscleral topography, which just shows substantial bilateral corneal and scleral irregularity. We used the SMAP 3D for this, and we ordered smaller, their scleral lens is 14.9 millimeters, but this is a young patient, and we wanted to promote, successful application removal of her lenses. So we ordered 14.9 millimeter diameter lenses. And we did a single remake because of insufficient central clearance in both eyes. And then eventually both lenses were fit with good clearance. You can see there on the OCT. We were able to significantly improve her vision. Obviously, we're still working on it. This lens is going to do multiple things. It's going to neutralize the irregular astigmatism. It's going to prevent further symblepharon formation. It's going to promote ocular surface protection because she does have exposure keratopathy. It's going to promote ocular surface restoration and again, prevention of amblyopia. Eventually, as we restore and protect the ocular surface, we're expecting some of that just corneal irregularity, hopefully some of that scarring to just resolve and eventually improve the vision, which will improve the overall just prognosis of amblyopia. And we still have 3 years to do that. So I'm really excited for her. I'm really excited that we were able to do this. Obviously, they had to come back several times for training. This is not an easy case. Scleral lenses are not that easy to apply and remove, but in a 4-year-old, it's even more challenging. But her parents were of a lot of help. Obviously, the most challenging aspect of the fitting process was to teach the parents the application removal and ensure the child's cooperation, because that's really just the key component here. And this is her and I. You can see on the photo on the top left, and that's her enjoying South Florida. She lives in Puerto Rico, so just enjoying the different sites here. So that's it for me. As you can see, scleral lenses are just so helpful in treating ocular surface disease. There's so many different indications for them. There's so many ways to troubleshoot potential complications that come up and customize the scleral lenses, not only the fit of the lens, not only the vision of the lens, but also what we're using to fill the lens in order to address different things that come about. And so I encourage you, if you are treating ocular surface disease, to explore avenues of scleral lenses and to explore how we can change patients' lives, patients' quality of life using scleral lenses. And with that, thank you so much for this opportunity. And if you have any questions, please don't hesitate to reach out.
Hi, everyone. I just want to welcome Dr. Elise Kramer. She is coming to us from sunny Miami, Florida, and I am so I'm always envious of all of our speakers that are coming in from beautiful, warm places. I'm coming to you from Minnesota, but I want to thank you very much, Dr. Kramer, for joining our program and taking on such an important topic.
Thank you for having me. It's a great opportunity, and I love working with you. So.
Yeah, no, it's a lot of fun, and you did a super job. I really learned a lot from your lecture. I just kind of want to maybe leave it open-ended in the beginning of our session here. Is there anything that you want to convey to all of our speakers that's really really one of the sort of most important, pearls that you want everybody to walk away from, from your talk?
Yeah, I think that, one of the most important indications of scleral lenses is dry eye. And a lot of people, when they think scleral lens, they think keratoconus, they think post-LASIK ectasia, they think corneal transplants, and rightfully so. But I think there's a huge population that can benefit from scleral lenses. And there are so many dry eye treatments out there, and they're all great. And I just think if you have scleral lenses in your toolbox, or someone who can help with that, it can just be invaluable for patients and life changing. And so, although there are, other aspects to treating dry eye, as I mentioned, and I talked a lot about evaporative dry eye and the pre-lens tear film, I just think scleral lenses can be life changing, and I want everyone to just kind of take that home from the presentation.
Awesome. And I can totally vouch for that. I mean, I know that you see these patients. I've seen a lot of patients over the years that I just don't know really what's the next thing that I really ought to do for this patient. And probably should have had them consider scleral lenses, before I actually ended up doing it, or recommending it. So would you say, is there a certain dry eye subgroup of patients that you think this patient's probably going to do well with a scleral lens?
I would say someone who's tried already a lot of different things. How many times a day can you put in artificial tears? When you see that that frequency is like more than 4 or 6, it's like it becomes a quality of life problem because putting in drops, every 2 hours, if you have an infection, it's temporary, but if you have dry eye, it's ongoing. And so that influences your quality of life. So those patients who've tried a bunch of things, they've tried immunomodulators, they've tried, amniotic membranes, they've tried all those in-office treatments. Those are great candidates because this is something that they can just put on in the morning and go about their day. And yes, they might have to do ancillary treatments as well, but it's a great complement and can be replacing some of the main treatments that they're doing. And a lot of patients will comment that the frequency of, the use of artificial tears is significantly decreased with a scleral lens. And so that can definitely improve quality of life. As I mentioned, having to put in a drop every hour, every 2 hours, chronically is affecting the quality of life. So those patients for sure. And I would say, exposure patients, because that's dry eye, secondary dry eye, right? But those patients, a tarsorrhaphy, for example, that's cosmetic, that's affecting their cosmetic appearance, whereas a scleral lens doesn't affect it. Um, and so that is a quality of life thing as well. And patients who have to tape their lids shut when they're sleeping or who have to wear moisture chamber goggles, these are life-changing things. So
Yeah. So thank you so much for saying that. I really love that part of your lecture too, where you talked about the wear time. For my knee-jerk reaction when a patient is struggling with dry eye disease and they're in a contact lens 12 hours a day, my knee-jerk reaction to that is, oh, I don't think that's really good for your eyes to have a piece of plastic in your eye for 12 hours. But that really opened my, kind of changed my outlook on things after listening to your lecture, really thinking of it as a scleral contact lens. It's really 12 hours of hydration. It's really 12 hours of.
yeah, so that's what you're giving those patients. You're giving them 12 or more hours of hydration. Ideal patients ask me all the time, what is the quantity of time I can use this lens? And I want them wearing it all day. I mean, I don't want them wearing it when they're sleeping unless they have severe exposure, and those are rare and, case by case situations. But if they are using a scleral lens, I want them to wear it all day. I want them to have that hydration. And sometimes I am having them put autologous serum tears. I am having them use Regenerization in their scleral lens or preservative-free artificial tears. I want all of that on the ocular surface while they're using it. So, the more they can use the lens, the better for me.
Awesome. Elise, I need you to help me with one other big,
Yeah.
huge thing in my clinical practice. Sometimes I just don't know how to articulate to the patient that has dry eye that a
Yeah.
contact lens is going to be good for them. Can you just help me kind of figure out what words do you use when you're explaining the concept of a contact lens for the treatment of dry eye? How do you
It's
kind of.
interesting because some patients say, I cannot use contact lenses because I have dry eye. And I say, well, my job is to find a way for you to tolerate a contact lens. That's my job, is to optimize the ocular surface so that they can use a contact lens. And in some cases, a contact lens is indicated to treat dry eye. And in that case, it's no longer considered a contact lens. It's a device, it's a treatment for it. So you look at it as a medical device and not a vision device anymore. And I think that's the transition, is that you look at it as something they use to treat dry eye. And what I do is I actually draw it out for them sometimes on this whiteboard I have in the office. And I show them how it doesn't touch the cornea. It actually lands on the conjunctiva overlying the sclera, and it will bathe the entire ocular surface in whatever you're filling the lens with the entire time you're wearing it. So it's extremely beneficial for a patient. So I think just transitioning over from a visual device to a medical device and explaining that and taking the time to explain what you're doing with the patient, that's important. And if you are using a disposable contact lens, explaining that your job is to help them tolerate that lens, that anyone can be a candidate for a contact lens, but there might have to be a few extra steps you have to take in order for them to do that.
And then do you recommend, certain different wear times for different patients or not really?
If I have a patient that has a poor endothelial cell count or a poor endothelial cell health, then I will see how they react to a scleral lens after 4 hours, and then I'll stretch it out. If they do get corneal edema, those patients, I may have them use the lenses a little bit less than other patients, but those are unusual. So most of the time, I don't have a limit to how much they can use them as long as they're not sleeping or napping with the lens on.
Awesome.
Yeah.
So there was another really cool part of your lecture. You showed this case where the patient had a significant amount of three to four plus PEK or SPK on their cornea, and their epithelium was clearly, sort of a rough epithelium. And then you showed a follow-up picture of how their eye looked like after they've been using a contact lens. I mean, do you typically see that like routinely in your
It
dry eye?
There are some cases like that, and those are some cases where I will give a patient a diagnostic scleral lens on the day of their consult because I know that they're already going to be better, even if the lens is not perfectly fitted and customized yet. These is like a band-aid, honestly, if you have a cornea that's that beat up and you put a scleral lens on top, it can be amazing. And that's a real case. That's a real case of a scleral lens, and that's what I would expect. Obviously, if you have a neurotrophic component or there's something underlying there that's exacerbating the PEE and it's coming secondarily from an underlying cause, that needs to be addressed. But if it's Sjogren's syndrome or if it's a Sika, keratoconjunctivitis Sika eye, that is primary, and you treat that with a scleral lens, those are the results I expect to see for sure. And especially with a nicely fitting lens, especially if you add a nice cocktail of preservative-free artificial tears, saline, preservative-free saline, of course, and even, some antibiotic from time to time.
Mhm. Awesome. One last thing I wanted to just kind of touch upon, how do you, in your patients that that they have an obstructive component and blepharitis and an
Yes.
evaporative component at the same time, you have a bunch of different factors that are affecting their ocular surface. How do you stay away from sort of overwhelming them, kind of doing in-office procedures and five things at home and scleral lens, care? How do you navigate that? Because that can be a little bit overwhelming for some of my patients too.
Oh, yeah. And if they walk out with all this information and they're more confused after they leave and then when they came in the first place, I think step by step, I think evaporative dry eye needs to be addressed probably first before a scleral lens even. And so what I like to do is on the day of a scleral lens evaluation, if I have a patient coming in for a scleral lens for dry eye, I will test to see if they have evaporative dry eye. And if they do, well, that day they're not leaving with a scleral lens, right? I have to order it, I have to design it, I have to, get it in the office, train them. So while they're at home, I like to get them to do homework on their evaporative components. So hot compresses, lid hygiene, artificial tears. And if I can, I'll do in-office procedures if they want to do that as well. And that way I jumpstart and I get their ocular surface optimized, and then when they get their scleral lens, then I can start maybe adding a few more things, but it's kind of a step by step. And I don't believe in kind of just throwing everything in at the same time. So definitely the evaporative component is something I like to address first because I know it's going to enhance my scleral lens success. And like I said, the scleral lens takes a few days anyway. So get them to do evaporative homework, in-office treatments, and then the scleral lens, and then add more after that if needed.
Awesome. That's, I mean, really, really, again, a great talk. I learned a great deal about ocular surface disease and sclerals. And again, thank you so much for joining us, Elise. Really appreciate
Thank
it.
you. Appreciate it.